Good morning, everyone. So we are now moving to our next session. It's about the adjuvant systemic therapy with a special reference to TKI. I will invite the chairperson for this session, Dr. N.T. Yawat sir, a senior consultant from Mumbai, to chair this session and to call the speakers.
Good morning, everyone. I'm Dr. N.T. Yawat. Actually, I'm not oncologist, but I was a HOD of pulmonary medicine. Currently, I'm an emeritus professor. But I have faced a lot of lung cancer. Once lung cancer is suspected or diagnosed, our job was to refer to Tata Hospital. So that I've done multiple times, except in emergency situation, we have to actually tap or put an ICD for recurrent pleural effusion. But there have been many advances, and now actually I'm interacting with you people. I must thank the organizer for giving this opportunity. The session is on adjuvant systemic therapy, TKI. The first speaker is Dr. Bharat Bhosale from Mumbai. I request him to take. He's going to talk on Osimertinib as adjuvant therapy in patients with resected EGFRm Stage 1B, 3A, NSCLC, updated results from ADORA trial.
Thank you, sir. And thank you, Astra, for giving this opportunity to present this updated survival analysis. So this data published a couple of years back, and still our debate continues. As Priya rightly said, in real world scenario, something happens because we don't, in India or many other lower middle income country where our interest lies, and these trials are conducted in high income countries. And that is why now, sometimes whether to do PET scan on follow-up, and the patient comes with the PET scan, and we feel that it's the right thing. Because we don't give Osimertinib to all, we don't give adjuvant immunotherapy all. How many of our patients are getting the standard of care in all those settings? And then what is standard of care? And the guidelines are for no insurance purposes, but in real world it is something different. Then we look at Vijay Patil to come with the low dose therapy in lung cancer also, or maybe 10 milligram dose of Osimertinib. So maybe then all the patients. What happens with the first generation TKI? I have seen patients are prescribed after the resection of, and they are taking TKI when there is no evidence, clear-cut evidence. But there are patients who have been resected and doing good. So we don't know the biology. So we are still in search of very good predictive marker, which patient should get. And right now, we just have two actionable mutations which are sensitive, 19 and 21. Apart from that, there are rare mutations which we are struggling to prescribe TKI in the advanced setting. So this is what the updated survival analysis of 3 years of adjuvant Osimertinib with or without chemotherapy. And I'm going to present what's the updated analysis is. So as you know, these are resected patients, stage 1B to 3A, and they have been stratified based on the mutation, kind of a mutation, Asian versus non-Asian, and stage. And 3 years of Osimertinib versus placebo, which is at present is the standard of care to observe after giving chemotherapy. Look at the graph, DFS benefit with adjuvant Osimertinib, which is for 3 years, and then calculate the cost. That is very important for the patients. Dr. Vanita has presented a paper where she looked at the usage of immunotherapy, which is again, I cannot compare the cost of immunotherapy with targeted therapy, but they concluded that 97% of their patients are not affording, but here cost is coming down thanks to AstraZeneca. Every year they are bringing down the cost. I again request Astra to bring down the cost so that number of patients will get more and more patients will get benefit. Look at the graphs. Those who can afford, definitely, if you prescribe a pill which is among all the TKI has least side effect, 1 year 97%, 2 year 90%, and 3 years it is 78%. 78% are living without cancer at the end of 3 years, and beyond 3 years, after stopping there is a drop. So the primary analysis, this is the primary analysis which showed a statistically significant and clinically meaningful benefit in terms of DFS with adjuvant Osimertinib, 3 years. So this is stage 2 and stage 3A, the first graph. And in the second graph, all stages, all patient included. At the 1 year, again, 97%, 2 year, 90%, and 3 year, nearly 80% of the patients are living without disease. by taking this pill. The clinical characteristics and demographics are well matched. What happened, the staging updated. So with eighth edition also, the difference, there is no difference. The clinical characteristics are same, the staging percentage of patient in each stage are same. And that also later on they looked at the survival and that did not change. So this was the primary endpoint, the updated DFS in stage 2 and 3A. You look at the median DFS in months, Osimertinib 65.8 months, nearly 66 months, versus placebo 22 months with hazard of 0.23. And then updated DFS in overall population, which included early stage 1B patients also. Again, the median is similar, 66 months nearly, and placebo 28 months with a hazard of 0.23. So hazard ratio looks very good. Somebody has to do a cost-effective analysis. Financial toxicity also important because there is no physical toxicity as compared to the first generation TKIs. This is, again, no, looking at the graph is always beautiful. Reality is different, but graphs, at least look for the next 2 days, we are going to look at many beautiful graphs, and this is one of the important graph where all subset of patients getting benefit by taking a pill, which can be, any other pill like hypertension or diabetes with some side effects. But Osimertinib again is well tolerated TKI amongst all the TKI. Updated DFS by stage. Stage 1B again, we can debate whether to offer these tablets, Osimertinib to those patients. But in stage 2 and 3, there is a clearly difference, good amount of difference in terms of reduction in the hazard ratio. Updated DFS by stage, again here you see the numbers are good enough to say in stage 2 and stage 3, at least there is a good amount of activity happening in reducing the recurrences, and patients are living. That's why the patients are living till the time the tablet is on. What happens in long term after stopping the tablet, maybe next we have to look at the next updated analysis. Till the time, again, I feel that the debate is on whether to prescribe or not. So these are the pattern of recurrence. This is very important. When you stop the tablet, what happens to the patients? This is what in the trial, and there are some retrospective analysis where people have looked at the kind of recurrence. In this trial, the amount of recurrence, maximum amount of patients recurred is in locally in lung, and followed by lymph nodes, a CNS metastasis, bone, and then various organs. So important thing is the surveillance is important. You have to pick up those recurrences happening in the lung, like breast cancer patient comes for regular follow-up, but there the clinical examination is easy. In lung cancer, clinical examination is not going to be easy, being an internal organ. So again, we have to debate what is the ideal modality of imaging on the follow-up for these patients, because substantially large number of patients are failing in the lung. So this is the updated CNS, and we always take this point as a support for the Osimertinib. While the patient is on, you can reduce the CNS recurrences, and then you can potentially cure this patient, because failing in the CNS is something like, you have very limited options after that in terms of cure. Except if there are oligomets, you can definitely do surgery or cyber knife or proton or whatever the modalities which can potentially be curable even in oligometastatic setting. So the number looks good even in those patients, Osimertinib and placebo. Again, you have to follow this data because the median is not reached, but the hazard ratio looks good, 0.24. This is a conditional probability of CNS and non-CNS recurrences in patients with stage 2 and 3A. And this is with, so the potential thing, what I personally feel, those who can afford definitely can be on this pill to reduce the CNS recurrences, because most of these patients who are going to get the CNS recurrences are going to be labeled as palliative, unless until those very small recurrences which can be managed in multidisciplinary team with discussions and surgery followed by stereotactic SBRT. Safety, I'm not going to talk much about Osimertinib because among all the TKI, as I said, this is what we can manage very well. Yes, it has its own side effect, and you see adverse events leading to discontinuation or death are very, very minimal. Diarrhea is a very peculiar characteristic of these side effects in all the TKI, but I don't think in Osimertinib this is a problem. Nail changes, skin changes, cough. ILD again, which is a problem with other TKI, is less seen with this, but again in this interstitial lung disease is reported 3%. So one must be careful, because always what happens in lung cancer patient, the patient comes, everybody puts everything on the recurrence or progression. One must make extra efforts to involve your pulmonology colleague, because recently I had a patient on Keytruda, and the patient was doing fantastic. Patient was of RCC with lung mets, and patient has excellent response, but developed a big lesion. Everybody looking at the scan will feel, it's a recurrence. We involved the entire team, and it was actually community-acquired pneumonia. We thought initially it's a disease versus immunotherapy side effect. But then there was extra effort to decide. Then it was actually a community-acquired pneumonia. We settled with the antibiotic. Patient has a low-grade fever, absolutely fine patient. 1 month after the initial lesion resolved completely, but the patient developed fluffy shadows. We again involved it. It's like immunotherapy side effects coming up in a grade 1, grade 2 manner. So now in the era of immunotherapy and targeted therapy, one must take extra effort to decide whether it's a TKI problem, it's a TKI side effect or immunotherapy side effect, rather than what we used to see, patients started coughing, just progression of this stop, because we have potentially many options to treat beyond 1 line, 2 line, 3 line, and we have seen patients tolerating this treatment. One most important thing is with the supportive care. If you assess your patient, and thanks to Dr. Narona, in the geriatric patient, if you assess them properly, you can choose the available treatment with appropriate dose reductions. So again, when you come with for the TKI also know how they should be given in the geriatric patient, because these patients are essentially on the polypharmacy. If you sit with the patient, they will give you 10 tablets. If you don't take the history properly, these patients have a lot of interactions. So the conclusion is, in this updated DFS analysis, Osimertinib versus standard of care, which is observation at present. Further 2 years of update. Overall, there is 77% reduction in the risk of disease recurrence or death with adjuvant Osimertinib for 3 years. Median DFS was nearly 66 months with Osimertinib and 22 months with the observation. There was also 73% reduction in the risk of disease recurrence or death with adjuvant Osimertinib in the overall population, including the stage 1B patients. Improvement in DFS was regardless of whether the patient received prior adjuvant chemotherapy based on the clinical stage and pathological stage. DFS benefit across disease stages was consistent following restaging, which happened with the 8th edition. Osimertinib demonstrated clinically meaningful improvement in CNS DFS, and that is probably the most important factor. One must discuss this option with the patient, because if you look at the data analysis, the debate will go on. But if somebody affords, then one must discuss this data with the patient. Not for all, obviously, with the financial toxicity keeping in mind. The safety profile was consistent with the established safety profile of Osimertinib, and no new safety concerns. This updated data reinforced adjuvant Osimertinib as a standard of care for patients with EGFR mutated stage 1B, 3A, NSCLC after complete tumor resection, with or without adjuvant chemotherapy. Maybe with the new urgent data coming up for surgeries, as an alternative to surgery for rectal cancer and many other cancer, in the future we really have to look at the what is happening with the circulating tumor, the DNA as a biomarker, and maybe in the future integrate all those clinical as well as the lab biomarkers, and then choose patients for adjuvant therapy. Because I feel somewhere we have to look at the data of first generation TKI also, what is happening with them. Because now at least everybody can afford first generation TKI, and maybe with that AstraZeneca will also bring down their cost significantly so that everybody can afford Osimertinib. Thank you. Thank you.
Thank you, Dr. Bhosale. Any question? Anybody has question? 1 or 2 questions can be permitted, is finished.
No question. I think I made all the points clear.
You have taken a very
Vijay is about to ask one question.
Yeah.
Now that you asked it, so
Not to me.
so if you look at the hazard ratios, The hazard ratio for exon 19 and exon 21 is different. That for 19 comes out to be 0.24 and that for the L858R comes out to be 0.45. Do you think exon 21 will be one side? Well, we know that
So-
in metastatic setting also we are now talking that exon 21 maybe not osimertinib something else. So this will be one side. Well, for adjuvant you want to think of something else.
Yeah, so whatever limited knowledge I got from you only about the statistics, I understand both the hazard ratio is good enough, and we have not pre-planned this analysis to look at but this is what basically important exon 19 versus exon 21. These are the two subsets where they stratified this. But I don't know whether this particular regarding to hazard ratio can be statistically significant. Can we say that? But 0.445 itself is a good justify whether I should prescribe it or not. Because we don't have a data of another TKI in this comparison.
Actually, I learned one point here. TKI is actually used to treat the pulmonary fibrosis, idiopathic pulmonary fibrosis, nintedanib.
Yeah.
But here I learned that 3% of the people got ILD in your study.
So this targets EGFR and nintedanib targets VEGF, vascular endothelial growth factor. So the mechanism of action is the receptor where they act is different receptors.
Good. Thank you very much.
Thank you so much. Thank you.
The next speaker is Dr. Rushabh Kotari from Ahmedabad. He's going to talk on adjuvant icotinib versus observation in patients with completely resected EGFR mutated stage 1B non-small cell lung cancer, a randomized phase 2 trial.
Thank you, sir, for introduction. I am a Cyan alumni, regards from me. And as sir told, putting ICD was the only thing I knew regarding cancer before joining Tata. Thank you, year-end review team, for this opportunity. So after the glamour of third generation TKI, we were back to first generation TKI, which is something which may be able to do in our majority of the patients. So adjuvant icotinib versus observation in patients with completely resected EGFR mutated stage 1B NSCLC. So they have been brave to select only 1B patients. As we all know that even in 1B, even after adjuvant chemotherapy in high-risk patient, there is a significant risk of recurrence in the tunes of 33% as per latest meta-analysis. So there is something which we need to do for such patients. But as we all know, there is no clear role of adjuvant treatment in stage 1B resected NSCLC. Even in chemotherapy, we give it to someone who has high-risk features because that is the only place where it has shown some overall survival benefit. So they have taken only stage 1B patient. There was another trial for stage 2 and 3A patient for the same drug. Icotinib is a first generation TKI. And I have realized that the interest in adjuvant TKI, even for the first generation TKI, has increased after ADORA trial. So traditionally we were taught that because we don't have overall survival benefit with first generation TKI, we are not supposed to give first generation TKI. But now with significant DFS hazard ratio, which we have not seen with previous TKIs, which we have seen in ADORA, even DFS has got some impact now while we are considering first generation TKI. So there were multiple trials with first generation TKI, majority of them showing DFS advantage. These were for some included stage 1B, some didn't. But most of them didn't show overall survival benefit. ADORA is still to show overall survival advantage, but even in longer follow-up, as Dr. Bharat showed, it is showing a significant disease-free survival advantage. It is difficult to ignore that graph. So this is a phase 2 open-label randomized study. Patients were recruited from May 2013 to December 2020. It was as per 7th TNM definition, completely resected EGFR mutated stage 1B patients. No patient received chemotherapy. There was 1:1 randomization for icotinib is to observation. Again, this was only 1 year of icotinib, while most of the TKIs, some are for 2 years, some are for 3 years. Primary endpoint was disease-free survival. A purist would need overall survival or quality of life. The secondary endpoints were overall survival and toxicity. So 128 patients were recruited, 63 nicotinib arm and 65 in observation, with a median follow-up of 34.9 months. Disease-free survival hazard ratio was 0.20. A confidence interval not crossing unity, a significant p-value. 3-year disease-free survival rate were 95.3% versus 86.7%. To the best of my knowledge, this disease-free survival is better than ADAURA also. But overall survival results are immature. Safety profile, this is an abstract, we don't have full paper, so it was written that it is well tolerated, no treatment related deaths. But first generation TKIs do come with rash, transaminitis and some GI disturbances. So we need to be cautious while we are giving it as an adjuvant treatment. So this was the only things mentioned in paper. Now, as I told, this is a debate which will never end. We have overall survival data with ADAURA, whether to consider overall survival to change your practice or DFS. DFS here is exciting 0.20 in stage 1B patient at 3 years. Such huge difference in disease-free survival is something which tempts us to use adjuvant TKI even in early stage disease. Adjuvant TKI landscape has many first generation TKI trials and ADAURA being the third generation molecule. So whether we will start prescribing first generation TKI in adjuvant setting without overall survival advantage. And the most important thing is the question is duration of TKI. So even in ADAURA we have seen that after 3 years there is a waning of curves. So curve starts coming down after 3 years. There are increase in recurrences after 3 years. So what is the exact duration till which we need to give TKI? Is it 3 years, 5 years, 1 year, 2 year? It is difficult to say. And whether giving the same drug in first line metastatic setting, we have same overall survival or not, it's difficult to say. So till we have overall survival data with ADAURA, the exciting disease-free survival hazard ratio is something which tempts us in affording patients. Whether the same disease-free survival hazard ratio or a bit higher disease-free survival ratio will tempt us to give adjuvant TKI first generation in resected patients is something which ponders us. So this is the curve for ADAURA. The 4-year disease-free survival rate is 80% versus 59%. You can see that hazard ratio is significant, but the 3-year hazard ratio with nicotinib was 0.20. So this is something for us to ponder on. Thank you.